I would like to invite Representative Freiberg to introduce his first bill on the agenda, House File 2152. We're going to provide about 75 minutes for discussion on this bill. Given the large number of people who have signed up to testify on this bill, after Representative Freiberg opening remarks, we will divide the remaining time between testifiers who wish to speak in favor of the legislation and those who want to speak against it. I would ask that testifiers try to keep their remarks to about 3 to 4 minutes each. We will not be timing each testifier, but I may ask you to wrap up your comments if they exceed this limit, out of respect for those still waiting to speak. We will take a brief pause for members' questions after we have heard from the testifiers on each side. Once the discussion on this bill is finished, we will take a quick break to let members of the public who came for this discussion to exit the room and give people in the overflow room a chance to fill any vacant seats in the rest of the agenda. I would like to say to the public who came here today that I would like to ask you to refrain from any type of demonstration or clapping during the hearing, which is not allowed. Yes, Representative.
With regard to testimony from the public, refrain from questions until all testifiers have completed on both sides, or at the conclusion of their testimony?
At the conclusion of each testifier, each block of time.
Okay. All right. Thank you.
Okay. So to that, Representative Freiberg.
Thank you, Chair Moran. Thank you, members of the committee, for being here during the interim. I appreciate it. And I do thank you sincerely, Chair Moran, for the thoughtful approach you've taken to hearing this issue. I think this is the right way to do it, to make sure we have a full understanding of this during the interim. I'm hopeful this can start a conversation and move on to more formal consideration of this bill, which is very important, which a lot of people have thoughts on. So once again, I appreciate your thoughtful approach. House File 2152 is modeled after Oregon's medical aid in dying law, which has been in place for nearly 2 decades. House File 2152 contains numerous safeguards to ensure that the law would not be abused and that people will not be pressured to undergo any medical procedure against their wishes. Under the bill, 2 doctors must verify that the patient has a terminal disease, and that's defined very specifically to mean that they have 6 months or less to live. A doctor must verify that the patient is of sound mind and understands the decision they are making. If those conditions are met, then a medical professional can prescribe a medication that the patient must self-administer to end their own life. They're not able to let anyone else give it to them. This is a decision they have to make themselves. There's public support for this approach. There's been a survey of Minnesotans showing that 73% support this legislation. That was a formal survey. We did a state fair poll a few years ago about this bill, which has been around for a few years. It showed that 66.8% of Minnesotans support this legislation with these safeguards in place. The state Senate did a similar poll and found 68.22% as well. So this is something that the general public broadly supports. The Oregon experience shows that the concerns raised by those who oppose this bill have simply not come to pass. To the contrary, end-of-life care has improved in Oregon, in large part due to the dialogue the Oregon law encourages between people and their doctors. Hospice use is high, and referrals are up, as is other use of palliative care. Some hospice programs in Oregon reported a 20% increase in referrals since medical aid in dying was authorized. In-hospital death rates in Oregon are the lowest in the nation. At-home death rates are the highest in the nation, and violent suicide among hospice patients has virtually disappeared. Right now in Minnesota, the only option cognitive terminally ill people have is to stop eating and drinking if they want to end their own life. This bill would provide an alternative to that extreme, difficult option and would spare their families, as well as themselves, the hardship of having to go through that process. Since I introduced this bill a few years ago the first time, I have heard from many heartbreaking stories. I've heard many heartbreaking stories from patients and loved ones of people who died in excruciating pain. You will likely hear some of those stories today. These are not people who want to die. These are people who are dying. House File 2152 would give many people peace of mind, and I do not believe the state should deny this option to people if they are making an informed decision. And I saw Senator Eaton was here in the audience too. She's worked really hard on this issue, and I appreciate her support and how hard she's worked on this. So those are my remarks, and let's hear from testifiers.
Thank you, Representative Freiberg. I would like to just open it up for a moment if anyone have any questions about the mechanics of the bill before we hear from testifiers. All right, thank you. And for, okay,
Madam Chair.
Representative Pearson, please.
Madam Chair, and again, it's the interim. I haven't read through everything, and I'm just coming here hoping to learn and understand. You're saying that the prescription is given when a person is of sound mind, but at the time that that person then administers the medication that ends their life, there's no guarantee at that time that that person is of sound mind. Is that right, Madam
Representative
Chair?
Freiberg.
The bill sets out a process, and if the healthcare professional has any concerns about the mental capacity of the person, then they have to get referred to a mental health care professional. I do have some testifiers. The author of the Oregon legislation is actually here, Barbara Coombs Lee. I should say she's not the legislative author, but she assisted with the development of the law and is very knowledgeable about how that has worked in Oregon. And if there are any technical questions, I'd welcome her to come up and speak to how it's played out in Oregon.
Okay. So why don't, Representative Albright.
Madam Chair, and I don't want to belabor the testimony and make people wait, but from a technical perspective, are we able to ask the author of the bill just a couple of questions that may pertain more to the to the provisions themselves?
Yes.
Thank you. Representative Freiberg on page 9, subdivision 13, and note that what you are availing of a healthcare provider is to essentially practice fraud. What you're suggesting here is that if they take an assisted suicide drug, the death certificate will not pronounce cause of death by the by suicide by the drugs taken in by the individual, but by the terminal illness. So in a sense, aren't you allowing the state to sanction the physician to practice fraud?
Representative Freiberg.
Thank you, Madam Chair. Thank you, Representative Albright. No. I'm not a medical professional, but my understanding is this is consistent with medical practice. If somebody is suffering from cancer and they are at the end of their life and they ultimately succumb to dehydration, that's the imminent cause of death, then that's the death certificate says that the cause of death is cancer. There are doctors in the room who can speak to that a little more clearly than I can, but that's my understanding of the basic answer to your question.
Representative Albright.
Representative Freiberg, along that same line then, because the insurance industry does not practice fulfillment of a death benefit based upon suicide, if the death certificate itself shows that the death was caused by terminal illness, aren't you again fraudulently presenting a death certificate to the insurance company for payment on that policy?
Representative Freiberg.
Thank you, Madam Chair. Thank you, Representative Albright. Again, the answer is no for the reasons I mentioned before. This is consistent with other medical practice and how death certificates are handled.
Representative Albright.
Thank you, Madam Chair. I don't see on the list anyone from the insurance industry or from commerce. I would imagine that if this were ever to see the light of day in a normal session, that those would be testifiers that we would look forward to hearing from, so I'll just leave it at that.
Okay. Representative New, did you have a question? Okay, thank you. So why don't the first testify, why don't we have Marianne Turnbull and Barbara Combs-Lee? Going to give
Madam-
Representative Freiberg.
Quick question, is it just procedurally, is it your preference that I stay up here through the duration of testimony? I know there'll be a lot of people moving back and forth, so if it's your preference, I can sit somewhere else while people are coming and going.
Yeah, so Representative Freiberg, if you can pull up another chair, that way we can have two testifiers join you
Okay.
as needed.
Sure. I don't know that I can pull up another, oh wait,
Okay,
yes,
just
I
take
can.
one. And so we're going to start right now. We're going to have 35 minutes for those who are supporting the bill, starting right now, and then it'll be 35 those who are opposing it. So welcome to the Health and Human Service Policy Committee. Please introduce yourself for the record, your name, and introduce who you're with.
Good afternoon, Rep. Moran and members of the committee. My name is Marianne Turnbull. I was born, raised, educated, worked at St. Paul Public Schools, raised my family, and currently reside in St. Paul. I've been an advocate for people with disabilities my entire life. You can ask my friends from high school. I'm here today in support of House File 2152, the End of Life Option Act, because on the first time that I got interested in this was when I watched my mother pass, and she actively suffered for over 24 hours. When I remember this, the scenes of this, I'm haunted with the images in my mind that are in my mind now from that. I'm also here because I've been told I don't have much time because I have cancer. I was diagnosed with stage 4 ovarian cancer about this time 4 years ago. I had been working with my doctor for 4 months, and the symptoms of ovarian cancer are incredibly vague, and it took her about 4 months to correctly diagnose what was happening, and at that time it was stage 4. And when you're at stage 4 ovarian cancer, I better read my notes. So because I was identified so late in the game, I had cancer in my fallopian tubes, my ovaries, my omentum, my colon, my diaphragm. And I had this ascites in my body. It looked like I was pregnant. And it became really clear at the first oncology appointment that I went to that I will die of ovarian cancer if I don't get hit by a bus first, or perhaps shot in St. Paul. I've already met up with the first frightful statistic that 85% of all people with ovarian cancer with stage 4 will recur, and I've recurred. And I've recurred. This is my 3rd time, and I am not feeling well now. Of the 20% of the women who get stage 4 ovarian cancer, 20% will live 5 years. I'm at year 4. With the help of my medical team, I've been able to live with the disease. It's become my new norm. Every day you think about cancer. I've undergone 2 major surgeries, 12 rounds of chemos, and there is no cure. There aren't even treatments that even like directly hit the cancer. So it knocks it down, it knocks you down, and then you get to come alive again with a whole bunch of new losses. I've spent a lot of days thinking about my life, contemplating the why me and how could it be. I mean, I was a yogi, I was a meditator, I do yoga, I eat organic, I did everything right, I drink water. I've spent a lot of time grieving the loss of my dreams. Like, how about a nice retirement? It's gone. But I've learned to respect the disease, And cancer's become a teacher for me, and it helps me learn what's important and really what's not important. So frankly, I contemplate the likely scenario of my death quite regularly. As it goes with ovarian cancer, maybe this year, maybe not. The chemo will no longer be effective at keeping the cancer at bay. There will be no other options. I've done my research of regarding deaths from ovarian cancer, and I've watched women in my ovarian cancer group die, just like the stats say. Following the end of effective chemo treatments, it's very likely that I will have intestinal blockages, ascites again, possibly fistulas that lead to fecal drainage, pain, symptoms from metastases to my vital organs, possibly my brain and my bones, and sepsis. Not a fun way to die. I don't know what lies ahead for me specifically. There's no telling how long a demise will last. It could be weeks, it could be days. All I know is it can be grim, even with the best of palliative care medicine. I'm here today to say I want to live as long as I can. I want the medical care that can ease my pain and allow me to be in relationship with my children, my family, and my friends. But when the time comes, I want a good death. I want to die at home. I want to be surrounded by people who love me. I want everybody to be in ritual and in prayer, holding hands with candles lit around me. I don't want to be in a hospital. I don't want to have tubes in me. I want to be at home. I want the option to have this medicine on my nightstand. That, my friends, will decrease the anxiety that I have every day living with cancer. And when my death becomes imminent, I want that decision. I want that option. I don't have the means to move to California or Colorado or Oregon. And just because of when I get there, I would have to find doctors who would allow me. I'd have to find a whole new care team. I can't do it. I need this bill to be considered. Let's learn. Let's talk openly. Let's solve this problem. This bill is intended for such a small population of people. I would never get involved in anything that would compromise people with disabilities. Never. That would be totally going against who I've been my whole life. As you can tell, it's very personal and it's urgent. I'm asking lawmakers to extend to me the same option that other dying Americans have. All I know is I want to be here in Minnesota with my care team and my family and my friends and the people who can support me. So please listen to the people of Minnesota. Please pass this Minnesota End of Life Options Act. Thank you, Rep. Moran. Thank you so much for listening to me and for acting. I appreciate it.
Thank you. My prayers are with you.
Does anyone have any questions?
We're going to go.
Okay.
Mrs. Lee, please introduce yourself and who you are.
Good morning, Committee Chair Moran, Vice Chair Morrison, other members of the committee. My name is Barbara Coombs Lee. I'm president of Compassionate Choices. Compassionate Choices is the nation's oldest and largest nonprofit, empowering everyone to chart their own end-of-life journey. I speak today on behalf of our 12,000 supporters in Minnesota. As Representative Freeberg mentioned, public polls show there's overwhelming support in the state of Minnesota for medical aid in dying, and that support is bipartisan, it is diverse, it spans every demographic group. In my experience, support is particularly strong among people who have had a personal experience with a difficult death, and it's particularly strong among people who feel passionate about having less government intrusion in their lives. No one wants to force anyone to participate. People simply want the option of medical aid in dying to escape suffering that may escalate rapidly as death inevitably approaches. Marianne was courageous enough to share with you some of the horrors that may lie in store for her because she's dying of ovarian cancer. People who want access to medical aid in dying are not making a decision to die. Their disease is taking their lives. They merely want a means to avoid this very worst, this very last part of the dying process if it becomes too much to bear. Medical aid in dying is entirely optional for both healthcare providers and patients. People with religious and moral objections can follow their conscience without withholding this merciful option from their neighbors and their fellow citizens. This bill is modeled after the 1994 Oregon law. I did co-author that law after seeing many people die in needless agony during my first career in emergency rooms and ICUs as a nurse and a physician assistant. I spent 25 years there. Since then, 9 jurisdictions have passed similar laws: Oregon, Washington, Montana, California, Colorado, Hawaii, Vermont, the District of Columbia, and New Jersey. Today, over 1 in 5 Americans live in a jurisdiction where medical aid in dying is available to them. Here are a few of the things we've learned in the last 25 years since Oregon passed this law. First, the eligibility criteria and the core safeguards do work to protect patients. In more than 40 years of combined experience across all these jurisdictions, there's been not a single instance of abuse or coercion that's been substantiated. People often confuse the situation of someone mentally competent and terminally ill. Living with people who are living with disabilities. But the two are completely opposite. Dying from a terminal illness and living with disabilities are two very different situations. And may I tell you that the people with disabilities in Oregon also cherish this law and find comfort in it. The second thing we've learned is that medical aid in dying improves end-of-life care across the board, and we did not expect this. Studies find that more open, candid conversations happen and better palliative care training happens in aid in dying states. Today, as Representative Freeberg mentioned, Oregon ranks in the top strata of end-of-life care with objective criteria: hospice penetration, home deaths, deaths in hospital. These are objective indicators that end-of-life care in Oregon is excellent. We certainly did not expect that mere access to medical aid in dying would bring such profound peace of mind, the profound peace of mind that Marianne wants. But we found that the quality of life improves so much that each year, about 35% of people who actually go through the process of obtaining medication die without ever taking it. Like other jurisdictions, medical aid in dying will account for less than 0.5% of terminally ill Minnesotans. Nevertheless, 100% of terminally ill Minnesotans will benefit because this law is on the books. Following a familiar pattern, patients will acquire a more open and empowered perspective. The medical community will respond. There will be better end-of-life care in Minnesota. Over the years, we've seen opponents raise very similar hypothetical scenarios and repeatedly misrepresent experience and reported events. I must tell you that these have not gone uninvestigated, that authorities, fair witnesses, have investigated these accusations. Police authorities, the regulatory agencies responsible, the Oregon Public Health Department, independent journalists, the Hospice Association have all been interested in whether or not any of these accusations are valid. None of these accusations have ever been substantiated, yet the same claims keep coming. Finally, we've learned that we authors were overzealous in our protections. These redundant procedures and arbitrary waiting periods we wrote are often insurmountable barriers for dying patients. Last year, a Kaiser study found that a third of eligible patients die before they can complete the exhausting, time-consuming process we laid out. So the debate comes down to this: who shall be allowed to decide how much pain and suffering on the deathbed is worthy and bearable? The dying person, in consultation with their doctors, their loved ones, their spiritual advisors? Or should it be the government, which its inflexible criminal law and its heavy-handed penalties? Terminally ill Minnesotans who would be eligible for medical aid in dying don't deserve obstruction with baseless speculations. And they don't have the luxury of endless deliberations. They need this merciful option now. Because not one additional person will die because you pass this law. Far fewer will suffer. Thank you.
Thank you so much. So we have 20 minutes left for those who are supporting this bill. Can we have Bobby Jacobson and Dr. Plimpton?
Get 35. Give it 15.
All right. Welcome to the Health and Human Service Policy Committee. Please introduce give us your name for the record and who you're with.
Thank you, Chairwoman Moran and Committee, for allowing me to testify today. My name is Bobby Jacobson. I live in Richfield, and am beginning my 23rd year living with an ALS diagnosis. Also known as Lou Gehrig's disease, ALS is a fatal disease of the nervous system. The signals my brain sends through the nerves that control movement are less frequently getting through to my muscles. I can no longer speak intelligibly, walk, dress, or toilet myself without assistance. I've been lucky to live so long with this disabling disease. I've held 7 newborn grandchildren in my arms and watched them grow into distinct little humans. 3 of them have graduated high school and are forging their way in the adult world. Most people with ALS are not so fortunate. My friend and former caregiver Stephanie, who is here in support of this issue, lost her uncle to ALS last Friday. He only got the diagnosis at the end of January this year. As a person living with a disability, I've gained great respect for the pioneers who fought for the Americans with Disabilities Act. It was their sacrifice and hard work that has given me access to so many support services that have enabled me to live a full life. But unlike others living with a disability, mine is fatal. While I am not in denial of this fact, I am determined to live life to the fullest as long as I can. But eventually I will lose my ability to eat without being fed through a tube, to breathe without attached to a machine that will do it for me, and would slowly suffocate without another that will suction fluid out of my lungs. Throughout all of this, my thinking will remain sharp, and my senses intact. Before I reach this stage, I'd like to have the option for a peaceful, painless death. Data from Oregon shows that after cancer, ALS is the second most common diagnosis of people who use that state's death with dignity law. I would like to have the same option. I may decide not to use it. but I want the option. Some in the disability community oppose medical aid in dying, but many of us support it. In the 20 years that the Oregon Death with Dignity law has been in effect, Disability Rights Oregon, the nonprofit that protects the rights of disabled individuals, has not had a single complaint of abuse. I am so grateful to the majority of Minnesotans who support medical aid in dying. Please let me and others with ALS, like my colleague Jerry, who is also here in support of this act, have peace of mind by supporting the End of Life Option Act. Thank you.
Thank you for your testimony. Please introduce yourself and who you're with.
Yes, Madam Chair, members of the committee, my name is Dr. David Plimpton, and I'm a retired physician, having practiced internal medicine and gastroenterology at Abbott Northwestern for 39 years. Though retired, I currently serve on the hospital's ethics committee, where we participate with colleagues and families engaged in difficult end-of-life discussions. In my long career, I've been at the bedside of many dying patients and would like to briefly bring a clinician's perspective to the topic of medical aid in dying. I also served on the Minnesota Medical Association Task Force that in 2016 undertook an extensive review of its long-standing opposition to physician aid in dying that culminated in the policy recommendations that were adopted in 2017. In summary, the MMA will not oppose legislation to authorize medical aid in dying as long as it adequately protects physicians and patients. Across the nation, the majority of physicians support medical aid in dying. Nationwide surveys show that between 2010 and 2018, support among physicians has increased from 40 to 57%, while opposition has decreased from 41 to 29%. And we have similar polling data from physicians in Minnesota. The American Academy of Family Physicians, the largest medical specialty group, which represents 300,000 family doctors, has adopted a stance that protects the primacy of the doctor-patient relationship and respects their members' freedom to provide medical aid in dying or to opt out as they see fit. Also, the American Medical Association's Council on Ethical and Judicial Affairs recently acknowledged that physicians may provide medical aid in dying without violating their professional obligations. To be in the presence of another person's suffering and to not be able to mitigate that suffering is one of the most morally distressing experiences that we as humans can face. I clearly recall the distress and frustration felt by the patients, families, and me as I helped guide two dear friends to their death by their having voluntarily stopped eating and drinking. Medical aid in dying would have been so much easier for all of us. As has been described, medical aid in dying allows the competent terminally ill adult to avoid unnecessary tests, treatment, and suffering, and assert control over the timing and manner of their inevitable death. The typical patient who qualifies for medical aid in dying is suffering from end stages of an untreatable disease, often cancer or a neuromuscular disorder. Most are enrolled in hospice and receiving maximum palliative care. Thus, the decision to use medical aid in dying is made in a setting where patients are surrounded by care and support from family, health professionals, social workers, and clergy. Now, I'd like to address a few common misconceptions about medical aid in dying. First, medical aid in dying is not assisted suicide. Suicide is a tragic result of cognitive impairment from a potentially reversible mental disorder, such as a major depressive disorder that causes those affected to want to die. Suicide is a violent, self-destructive act, often completed in isolation. In contrast, those who use medical aid in dying have clear thinking, are connected to family, and choose a peaceful means to shorten the dying process. They want to live, as already been stated, but they are dying and experiencing not depression, but a grief reaction, which may be so profound that it interferes with the quality of their remaining time. The American Association of Suicidology, a multidisciplinary association of health professionals and individuals whose mission is to apply sound research to suicide prevention. The AAS's policy is also included in your packet and clearly states that medical aid in dying is not the same as assisted suicide, which will remain against the law. Second, some argue that medical aid in dying is not necessary because physicians can provide palliative sedation, in which physicians sedate the patient into a comatose state to relieve suffering. And I have provided this upon occasion during my career. While palliative sedation is absolutely indicated for those with intractable suffering who have lost the capacity to speak for themselves, it does not address the very real needs of dying patients who wish to preserve their cognition, their sense of self, and to end their suffering on their own terms before their terminal disease and the dying process incapacitates them.
Dr. Plimpton, I need you to wrap it up.
Yeah. Medical aid in dying is neither rife with abuse nor an indictment of those with disabilities. Finally, the End of Options Act is designed to respect individual providers, as already been stated. They can opt out for religious beliefs. No doctor, nurse, pharmacist, or health professional is ever required or forced to participate. I urge that you consider favorably House File 2152. Thank you for allowing me to speak.
Thank you for your testimony. Can I have Reverend Limpert and Tara Guy? Is Tara Guy available?
Good afternoon, and thank you for the opportunity to speak. My name is Harlan Limpert. I'm a Unitarian Universalist minister, a former hospital chaplain, and founding member of Interfaith Clergy for End-of-Life Options. We are an association of Minnesota clergy representing 6 Protestant denominations and Reformed Judaism. Our mission is to promote understanding and acceptance of diverse spiritual beliefs related to end-of-life decisions. We are united in our support of a full range of end-of-life options, including medical aid in dying. As faith leaders, we have witnessed firsthand the existential suffering of people in their last months, weeks, and days of life. Most of us have held the hands of people who have fought the good fight against cancer, ALS, and so many other progressive terminal illnesses. They are exhausted. They've done their best. Their medical teams have performed every miracle of modern medicine and provided every means of comfort. Their families, in many instances, have cared for and supported them, sometimes for years, and yet their suffering continues. We support their right to choose a peaceful death. People of goodwill and strong faith have differing views about medical aid in dying and make differing decisions when they face the end of life. Some will find deep spiritual meaning in suffering. Others find human dignity in preserving their consciousness and meaning in suffering. Some find deep spiritual meaning in their suffering. And others find human dignity in preserving the consciousness and sense of self at the end of life. Some surrender to a higher power, while others find meaning in the exercise of personal autonomy. Some find connection in caring for and depending upon others. Some cling to their identity as self-reliant individuals, but no way is more right than another. No way is more moral than another. What is important is to recognize that all perspectives are valid and should be respected. No one religious viewpoint should dictate what is spiritually right for everyone. My own religious tradition honors the worth and dignity of every individual and the sanctity and integrity of individual conscience. We believe that each and every person lives their life in relationship with their Creator as they best understand that relationship to be, and to determine for themselves what makes life worth living. Ultimate questions of life and death belong to the person who is dying, not to the government and not to a religious entity. According to Lifeway Research and evangelical survey research organizations, Christians find medical aid in dying to be morally acceptable, including the majority of Protestants and Catholics. I brought a handout with a link to the survey results, as well as a statewide survey that confirms the findings here in Minnesota. I'd like to close with the inspiring words of California Governor Jerry Brown, who spent many years training, as many of you know, in a Jesuit seminary. He wrote this as he signed the California End-of-Life Options Act into law. He said, "I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I would not deny that right to others." I will also be submitting a statement by the Reverend Dr. Margaret McCrae, a Presbyterian minister who is with us today, in support of this legislation. Please, please, please find it in your heart to support the Minnesota End-of-Life Options Act. Thank you.
Thank you for your testimony. Is Tara Guy available here? Okay, David Mayo. Tara?
Yes. Thank you, Madam Chair, members of the committee.
Please reintroduce yourself for the record and
Tara Guy,
who you with.
Roseville, Minnesota. Thank you for allowing me to tell you today the story of my bright and sunny friend Doris. You know, we were best friends for more than 30 years, sharing much as older best friends do. The death of parents, the birth of children and grandchildren, and always lots of laughs. It broke my heart that despite vigilant self-care and twice yearly screening tests because of her own family history of ovarian cancer, Doris was diagnosed with late-stage ovarian cancer. Over the ensuing 6 months, Doris underwent major surgery, 2 courses of debilitating chemo and radiation. Not long after the chemo, while on a walk, Doris was struck by a drunk driver. She suffered critical near-fatal injuries and spent 3 more months in the hospital. Although she survived, her life was filled with even more pain, disability, and exhaustion, but she soldiered on. It was during this time, while still recovering from her traumatic injuries, that her cancer returned and her remarkable energy and her strong will began to flag. She privately confessed to me that she was exhausted. She had witnessed her 2 sisters die of ovarian cancer. She knew what lay ahead, and she was destined to lose this battle. Encouraged by her loved ones, however, she agreed to one more round. After suffering through the treatments again and beating the cancer back for a time, it came roaring back in a matter of 3 months. And this time, Doris declared she would take no further treatment, but rather she determined to enjoy whatever time she had left with family and friends, opting solely for palliative care. Gradually, Doris became so sick and weak that she couldn't keep up the facade any longer. She longed for it to be over and simply wanted to rest. On a hot, early July morning, Doris swallowed all of the painkillers, sleeping pills, and tranquilizers she had stockpiled for weeks, leaving a letter of apology containing words of love and a plea for understanding, along with her copy of her advance directive. She lay down in her bed to peacefully leave this world on her own terms. Unfortunately, Doris's boyfriend arrived home, found her comatose, and rushed her to the hospital where she was placed on life support. That was the beginning of a 6-day nightmare during which Doris's daughter, Stacy, an RN, produced the advance directive and demanded to have her mother removed from life support. Eventually, the ventilator was removed and Doris was allowed to die days later, but all of this could have been avoided. Doris should never have had to resort to such desperate measures. She should have had the option for medical aid in dying. And when I read about people in California and Oregon who are able to have a peaceful death surrounded by their families, I get angry. The freedom to have a peaceful death should not depend on where you live. I vowed to Doris that I would take up the work of ensuring that no one else ever had to endure what she had in her simple wish to go to her final rest. I urge Minnesota lawmakers to listen to your constituents and grant terminally ill Minnesotans the compassionate option of medical aid in dying. Thank you very much.
Okay, thank you. Please introduce yourself for the record.
Good afternoon, Representative Moran and members of the committee. My name is David Mayo. I'm a resident of St. Paul, and I'm an academic, and I think I'm going to bring a slightly more analytical slant to this. I hold a PhD in philosophy. I've taught bioethics for 30 years at the University of Minnesota Duluth. I'm a faculty associate emeritus at the University of Minnesota Center for Bioethics. And I've also served on the board of directors of the Death with Dignity National Center, a real tongue twister here. I'm here to testify in favor of the bill. Philosophers love to present arguments, and I'm going to try to present at least a different angle for looking at this. But since so much of what I had to say has already been said, I won't take your time with that. I want to make a few remarks about slippery slope arguments, which have not been mentioned explicitly, but I suspect that they may be in the next hour. Slippery slope arguments are arguments to the effect that we're at the top of a terrible slippery slope, and if we take this fateful step, we're going to slide down until we wind up in Nazi Germany's death camps. I believe some slippery slope arguments are sound. Don't eat that one potato chip. You won't be able to stop. Don't skip your workout even once. But more often than not, in the context of public policy debates, I think they're more accurately described as slippery teetoters, which are usually grounded in opposed ideological commitments, where the evils envisioned by parties at one end of the teeter-totter are viewed as moral or social progress by those at the other end. And I suggest that the ends of this debate are on the one hand a commitment to the view that life is always valuable under any circumstances. We must never do anything that doesn't prolong life as long as possible. And at the other end, a commitment to patient autonomy and the right to informed consent. And I think the last 55 years has seen a move from rampant medical paternalism, where doctors even debated in the journals about whether terminally ill cancer patients should be told of their diagnosis, to acceptance, recognition in the law, and in practice of a patient's right to self-determination. And I see most of the changes in end-of-life care along this continuum. In the 70s, hospice was introduced, to the horror and shock and dismay of the people who opposed this bill, for the most part, and with the same arguments, because here a step was taken away from the view that patients and everybody's life must be preserved at all costs. Under any circumstances, their wishes to the contrary be damned. The same objections by many of the same parties were heard even louder when living wills were introduced in the early 70s. These gave people the right to state what they wanted by way of care at the end of life. But that didn't work out so well. Doctors ignored them. And it turns out that in practice, if a patient doesn't have a powerful advocate working for them, this isn't going to come to much. So advance directives are sort of an evolved form of this. And organizations promoting advance directives invite people to think about what they want at the end of life. Think about what's important to them. And then put that in writing. And then designate a healthcare proxy who has the legal authority to make end-of-life decisions for them if they're not able to speak for themselves. I think Every step of the way, we've been told, if you take this next step, hospice, if you take this next step, living wills, if you take this next step, healthcare proxies, we're stepping on a terrible slippery slope. But I would argue that while there is a slope, the slope is of increasing recognition of the right to self-determination and a weakening commitment to the view that life must be prolonged no matter what the cost and in every possible way. And I just suggest you to think about debate in this context. This isn't something out of whole cloth and out of the blue. This is just the evolution, in my view, moral progress towards greater respect for the patient's right to determination. Thank you very much.
Thank you so much for your testimony. So we're going to add 10 minutes to each side, but for the next testifier, please try to keep it at 3 to 4 minutes. Stephanie Jerk, and April Kane. Welcome to the Committee on Health and Human Service Policy. Please introduce yourself for the record.
Good afternoon. My name is Stephanie Jurek. My name is Stephanie Jurek. I live in Webster, and I am testifying in support of HF 2152, the End of Life Option Act. Yesterday, I did the eulogy for my uncle's funeral. He was 82 and had ALS. He was diagnosed in January. He was still driving his car in April. He declined so fast. He had no time to digest what was happening to his body. He begged me the last 3 months to help him end his life. I couldn't do anything but watch him lose his ability to walk, talk, bathe, and feed himself. He was in a power chair nearly 24 hours a day. Watching my aunt care for him day in and day out was difficult to watch as well because of the toll it took on her. I'm also a PCA, and I cared for my uncle daily. And I helped do daily cares for my friends Bobby with ALS and Phyllis with polio, who are also here. I watched the struggle they have in their lives. Let them choose how to close out this chapter of their lives. I had a neighbor and friend who accidentally blew up her face with a cigarette smoking with her oxygen on. She suffered terribly for months after, going from hospital to transition care, where she broke her hip, and back to the hospital. Finally, her family and her doctor together decided her only option was to stop using her oxygen until she passed away. She hallucinated for days, and the nurses in the hospital didn't know how to care for her, so they put her in Depends and strapped her to the bed. Days she lay there until she died. I sat with her many times, many days, and tried to talk her through those hallucinations while the nurses only argued with her. It was heartbreaking and unnecessary. I am very Catholic. I don't necessarily believe this is right for me, but I believe I need to be the advocate for the people I cared for who wanted this. We believe this was right, who believe this is right for them. I've been married for a year to my current husband. Prior to that, my previous husband died after 22 years of being sick. My current husband's wife died of cancer a few months before we met. Both of them suffered greatly, but we all trusted God's will. I realize that there are people and lawmakers in particular that are pro-life who are against this bill. I respect that. But not all of us have the same belief system or the same God, or any God for that matter. Who are we to judge other people, and in particular, how they should suffer? Please set aside your partisanship and help the people who are truly suffering. It's too late to help my uncle, but please help my friends. Thank you.
Thank you for your testimony. Please introduce yourself.
Madam Chair and members, my name is April Kane. My father was 67 years old, and he was dying of terminal end-stage lung cancer because he had been a chain smoker his entire adult life. His last wish on this earth was to die at home. I helped him. We didn't have any help back then. There were no yellow shirts. This was 20 years ago. My father drank 2/3 of a bottle of liquid morphine, and he thought he'd be dead in 15 minutes. But 5 hours later, he was not dead. And it was the most horrible experience of my life that 20 years later, I am still scarred by. Everyone has one beautiful life, and it's their decision if they die at home, if they extend the dying process. My father was emaciated. He was a skeleton. He was bedridden in adult diaper. He couldn't stand up. He couldn't feed himself. He couldn't go to the bathroom. His last wish was to die at home, and he should not have suffered that way. After 5 hours, he tried to drink some more liquid morphine, and he aspirated and died. So for every yellow shirt in this room, and for every yellow shirt in the overview room and at home, I thank you from the bottom of my heart, and keep speaking as loud and as relentlessly as you can, because nobody should experience what my father experienced, nor should I. And everyone has a right to decide where to die and how long to extend the dying process. Thank you.
Thank you so much. Members, do we have any questions or? For any of the testifiers? Okay, Representative Morrison.
Thank you, Madam Chair. I just have one question, I think for Dr. Plimpton, if he wouldn't mind returning to the table. Thank you. Thank you for your testimony and for being here today. I was looking at the Oregon Health Department annual report, trying to understand what we can learn from Oregon's experience, and found that of the 249 patients who received a prescription for medical aid in dying in 2018, only 3 were referred for a mental health evaluation. And I'm just wondering, I think some people are concerned that people have depression when they choose to do this, and I'm wondering if we're missing something there.
I have no precise information, no documented information on why that might exist, but I can speculate. And I suspect that the process of screening patients
Can we
successfully,
excuse me, testifier. I just want to say to the public, can you quietly leave the room? We're still testifying. Thank you. Okay, sorry, go ahead.
that the screening process successfully identified the people who had primary depressive disorder, not just a grief reaction. And although there are some similarities, they are not the same thing.
Thank you. Did you have anything you want to add?
Ms. Lee?
Yes. Well, I would clarify that there is a mental health evaluation. It's performed by the physicians who do the attending physician evaluation and the consulting physician evaluation. Physicians do this all the time. Every single time a person gives informed consent, the physician makes a judgment, is this person capable of making informed consent? And the presumption is that a person is mentally capable unless there are signs that they somehow are mentally incapable. So 2 physicians assess the patient and must attest to their affirmative finding that this person was mentally capable, not suffering from a psychological illness that would impair judgment. So yes, only, however, if one of those physicians has a doubt, is there a requirement for a mental health evaluation, a full mental health evaluation by a mental health professional. What has been found is that just routinely saying every single person who makes a request for medical aid in dying shall be deemed incompetent until proven otherwise, and will have to show their rational mind to a mental health professional. It turns out that that's one of those insurmountable barriers that is just too onerous, that a dying person is likely to be too weak and unable to find their way to a mental health professional and get that evaluation.
Thank you.
Morrison?
Thank you both for your testimony today.
Okay, Representative Edison.
Thank you, Madam Chair. Thank you, Representative Freiberg, for bringing this bill. And I want to thank all the testifiers. Marion, I don't know where you are, but thank you for sharing your story. It's a very complex, emotionally driven issue, and I know it's going to just get more emotionally charged. I have a question. In terms of Bobby had brought up that ALS is the second largest group that uses medical aid in dying. What is the first largest group?
Cancer.
Cancer. Okay. I will say, in terms of the audience, have many of you seen someone that you love die of a terminal illness? So have I. 11 years ago, my dear friend died of bone cancer, and I watched her every single day and her physician husband as she withered away. And I want to thank you for bringing this legislation because she had no options. And what I realized is when she wanted this to her life she wanted it to be done, the pain to be over, that we villainized her as someone that was sick. So thank you so much.
Representative Pinto?
Thank you, Madam Chair. I guess my question is for Ms. Coombs-Lee. So we've referred to pain and suffering and avoidance of those things and of agony as being obviously drivers for the bill. But one thing that jumped out at me was that although the terminal illness is one of the issues that has to be certified by the prescriber, I was surprised actually to see that there was not a reference to those sorts of requirements. I'm just wondering if there are other legislation around the country that have that, or if you could talk to that point about why it is that although a terminal illness is referenced, there's not in the bill in terms of the requirements that are in there, there's not a requirement of any particular finding, at least I didn't see it, maybe I missed it, that the terminal illness involved those sorts of elements that are being referred to in your testimony.
Ms. Lee?
I'm sorry, may I clarify your question? Are you suggesting that there should be a requirement in the bill that the person be suffering unbearably at the time of request?
Representative.
Thank you, Madam Chair. I'm certainly not suggesting that. I guess I found it, I was surprised that there was no reference, since that is a justification that I hear quite a bit. I guess, so just to say what I hear is the justification is a concern for unnecessary suffering and agony in the process of dying, and then, of course, also for individual autonomy. Those are two things. And regarding the first of those, that suffering and agony, I guess I had thought in looking at the requirements that might be something that would be included. I'm not necessarily suggesting that it be or how it would be, but it was a notable omission for me when I'm trying to understand the bill.
Ms. Lee?
Well, I think it's included by vesting an individual in the trust and autonomy to make a judgment about what agonies their particular illness might bring to them, how much they fear those agonies, and how much insurance they might want to acquire against those agonies. As we heard, end-of-life suffering, particularly with people with cancer, often escalates rapidly at the end of life, sometimes with no warning. But people like Marianne, who are courageous enough to ask the doctor, what's it like? What's it going to be like for me, doc, at the end? And here, like Brittany Menard did, you will probably be in constant seizures, a situation we call status epilepticus, and you will be seizing continuously. Or like a friend of mine with a lung cancer who learned, well, it will probably be a pulmonary hemorrhage, and you'll probably drown in your blood. Or people with bowel cancer who hear that bowel obstruction means that they'll probably be vomiting fecal matter at the end of life. This might happen very precipitously, and people want to have in their hands the ability to escape that if it looks like it's on the horizon. There it is, it's coming now. I'm starting to spit up blood. There it is, my bowels are starting to be blocked. Now is my time. People don't take their medication prematurely. They take it when their worst nightmare is approaching them and death is imminent. And that explains why every year a third die without ever taking their medication, because they never confront their worst nightmare.
Representative Pinto?
Thank you, Madam Chair. I guess and you should understand, I come at this as somebody who's just really trying to understand, and I very much appreciate Representative Freiberg for his work on this and many other bills and his leadership. and I'm very sympathetic to a number of the goals. But I guess if I'm understanding your testimony correctly, then even if the bill works perfectly, there's no requirement that the terminal illness involve in any way. Although we've brought up about suffering and pain and agony they want to avoid, the focus really is there has to be that terminal illness of a number of months, and then certainly we're lifting up patient autonomy to, as you described, then to choose the time. And of course, so often these situations do involve those things. I do not want to downplay that. I'm just trying to understand the mechanics of the bill in that way.
Ms. Lee?
Yes. I guess the basic philosophy behind the bill is that people get to own their own suffering. They get to define their own suffering. They get to have their own worst fears. My worst fears might be different from your worst fears. And so people who are terminally ill and mentally capable qualify, and then they're trusted. And over the years, I think one of the things that we've seen is that trust is well vested. There's no death wish. People don't have a death wish because they make a decision to request medical aid in dying. They want to hold on as long as they can. They keep their medication until their worst nightmare is in view.
And maybe one.
Representative.
Thank you, Madam Chair, and thanks for indulging. This will be really quick. I'm just wondering, Ms. Crimsley, if you're aware of any other legislation around the country that does have that requirement where the prescriber says a terminal illness of a short period of time that is expected to involve suffering or pain or that sort of thing. It sounds like the answer is no, but I just want to, as long as you're here, to take advantage of your expertise.
No, and I don't. I mean, I would be interested in language that you think would be effective in that regard. I have trouble imagining language that would be universal and that would be broad enough to encompass every individual's personal experience of suffering.
Representative Pearson?
Thank you, Madam Chair. And I actually asked Representative Freiberg the question prior, and I actually wouldn't mind your insight on the same question. We're checking a person's state of mind at the time of prescribing the medication that will end their life. That can be done on a diagnosis of someone is expected to pass away within 6 months. We don't have any other cross-reference to know that this person is in a proper state of mind at the time they make the final choice to end their life. I'm actually very concerned about that specific element and lack of attention within this legislation or anything that I'm hearing about the legislation that's currently in effect in Oregon.
Representative Freiberg?
Sure, I guess I would just say doctors, as we've already heard, doctors make these sorts of decisions about the patient's capacity all the time. And I view attending physicians as much more capable of making those decisions as whether they are of capacity. And if they're uncertain, then there's a process, as has been described, where they can be referred for further evaluation by a mental health professional. I trust doctors certainly more than I trust government officials to make that decision, but I'd be interested to hear from Ms. Coombsley to experience in Oregon.
Ms. Lee?
I've contemplated this question many times over the years. And the way it works out is that everyone understands when a patient acquires the medication that they retain the ability to take it so long as they can make an affirmative decision and take a voluntary action to ingest the medication. That's the common understanding. Families understand that. Physicians understand that. Patients understand that. I hear the desire for some kind of another check proximate to the time that the patient actually takes the medication. I've struggled with a provision that could be devised that would not be so intrusive and onerous. The idea of inviting a person, perhaps a government representative, into the family circle at a time that is so private and so personal and so full of grief. I struggle with how to craft a provision that would give that extra layer of assurance that you're looking for, that would not be just onerous and offensive invasion of privacy of a dying person.
Representative Pearson?
Well, I mean, I have a whole separate line of thought on that, everything from someone who's in seizures not being able to take the medication. There's, you reference that, and then so if someone is assisting them, that's a violation of this, and that's a huge issue. I actually don't want that addressed right now, but I think it's a challenging predicament to put family members into as we listen to testimony of those who have sat in witness as family members have taken their own lives. It's a awful, horrendous, horrific experience, and I apologize that you've had to go through that. But here they have a medication that allows them to commit suicide, and if anyone helps with that, you know, again, we're all good people wanting to follow the wishes of our parents, our brothers, our sisters, our neighbors. And, you know, it's a challenging position to put people into. I guess in looking at just some of the survey results coming out of Oregon also, the reasons that doctors are reporting of why their patients wanted assisted suicide in Oregon, they're almost all disability related versus pain and suffering, as Representative Pinto has talked about. 49% of folks feel that they're going to be a burden on others. 93% of people reference a loss of autonomy. 73% a loss of dignity. Well, these are all disability issues, and I still find this bill lacking in that range of scope. And I respect autonomy. I'm probably more libertarian than most in the room, and yet here we are talking about these issues and talking about them being burdens, as opposed to what the testimony that's been given here today. So I guess I'm just going to leave that as a statement at this point without asking questions, and certainly at the chair's discretion. If you want the testifiers to respond, that's fine. That's your choice.
Mrs. Lee.
I would just highlight the limitations of those surveys. First of all, they do not ask the patients. They ask the physicians what they think were the patient's motivations, and it doesn't say just one. So most of those surveys are tick, 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 all those things. So the statistics that you cited means that those were cited by physicians, which they guessed were motivations of patients in this percentage of time. The questionnaires do not still have the foresight of adding fear of future suffering or anticipation of future suffering. That's not one of the choices. So loss of autonomy, patients identify that. The degradation of personhood. I don't, for example, want to die in a state of delirium or comatose or suffering unbearably in front of my family. Those all get lumped under some of the categories that you mentioned without being more specific.
Representative New.
Thank you, Madam Chair. I don't know if Ms. Jacobson is able to respond or if anyone else knows, but I do think this statistic that the group of people who use assisted suicide, the second largest group is those with ALS. I am wondering if we know statistically how long after diagnosis those folks choose to go through with the assisted suicide. I think this is a unique group of people, and I'm wondering how long after diagnosis those folks choose to administer the assisted suicide.
Is Bobby Jacobson still here? Oh.
She said she thinks Stephanie
Okay.
would be better suited to respond to that.
Okay. Is there anyone who can respond to the question? Ms. Lee or
I don't know if that would be, as you know, ALS has a enormous variability in the progression. My brother-in-law died of ALS, and he had a very short time from diagnosis to death. Yet some people live for years and years, and the progression is very, very slow. So I don't know if that particular statistic would be especially useful.
Madam Chair. I happen to think that with ALS particularly, it'd be very useful. The average lifespan is 2 to 5 years. 90% of people with ALS die within 5 years. It's not widely variable, actually. Very few people, it's a miracle that Ms. Jacobson has lived as long as she is, and what a blessing that is, but it's actually not widely variable. It's a pretty relentless progression when it's ALS. And of course, we know that the disease mechanism with ALS is that the nerves stop, in layman's terms, the nerves stop talking to the muscles. And so a patient relatively quickly can lose the ability to self-administer, which is why I'm wondering how soon after diagnosis folks with ALS would self-administer, because we do know that, and what is wildly variable is in ALS is how the disease progresses. It affects everyone just a little bit differently. But I think that's significant. In order to self-administer, are these folks choosing to die in 6 months when they don't know? They very well could live 20 years. But in order to self-administer, are folks choosing to do that long before their healthy, reasonably healthy life is that they would lose that ability?
We don't.
One thing I could say is that if they have a prognosis that they will live for 2 to 5 years, they will not be eligible for the bill. This bill only applies in cases where their prognosis is 6 months or less.
Representative.
Mrs. Jacobson. Go ahead.
Well,
Did you get that?
no.
She was saying basically that you don't consider.
Can you give us your name for the record real quick?
Oh, my apologies. Chester Jacobson, Bobby's husband.
Okay, thank you.
The most patients would not consider taking the medication at the beginning of diagnosis, or even thinking about it at that time. You think about it at the end, of course, when you can't do a lot of the functions. Yes, and she's saying when the doctors tell you that you have less than 6 months to live, which of course is not at the beginning of the diagnosis, it's more towards the end. If that might answer the question.
Yeah, that was very helpful. Representative New?
That's fine.
Okay, our last question is coming from Representative Schultz.
Thank you, Madam Chair. I just want to thank all the advocates and Representative Freiberg for bringing this bill forward. I'm a co-author and I support this bill. I have a lot of constituents in my district that actually would like to expand this. They have Alzheimer's and dementia, and we've had several hearings in Duluth. There's quite a bit of support for this legislation. And I have personal experience. My father had a terminal cancer diagnosis and passed away at age 60, and it would have been a much better death if he could control his own death and the timing of that death. And he served in Vietnam, and he was always very perplexed that he served our country and could have died protecting our country, but he did not have the ability to control his own death. So thank you all for being here and for advocating.
Well, so thank you so much for testifying. We're going to move on to the testifiers who are opposed to this bill. We have 45 minutes of testimony, starting with Brian Callister. No, I'm sorry, we're going to have Iman Assad Zaman. Okay. And then Brian Callister. Okay. Can we have some quiet in the room, please? Thank you. Okay, let's start. Please introduce yourself for the record.
Madam Chair, representatives, I am Imam Assad Zaman, Executive Director of the Muslim American Society of Minnesota. First of all, I want to thank you for convening this conversation. As a faith leader, I feel my perspective has broadened significantly by listening to all the stories that I have sat through and listened. Of course, these stories are not new to me as a faith leader because I am frequently called on to help counsel families as they deal with the transition of a loved one to the next life. I want to tell you one story that jumps out at me because it did not affect me personally, but affected somebody very close to me. My best friend, my predecessor in my current job, was Imam Hisham Hussein. Many of you have interacted with him. His wife, more than 15 years ago, was diagnosed with a very aggressive form of thyroid cancer. Doctors at that time gave her 6 months or less to live. And given that I was her husband's best friend and was very good friends with her, I was involved in their family's preparation for this inevitable catastrophe. She had 4 kids at that time. I literally remember a conversation with her where she asked me to promise to help her husband find a wife who could be a stepmother to her 4 kids. I literally remember telling her, do not think this way. And she's like, listen, we'll not think this way, but it could happen, so we need to prepare for it. She gave me a series of instructions on how the children are to be raised. And as she was about to start chemotherapy, they discovered that she was pregnant. And the medical advice, and I actually concurred with this advice, was that she should abort the fetus so she could start chemotherapy. She decided not to do so. And I tried to talk her out of it. She said, listen, this is going to be my miracle baby. I am ready to die for this baby. And she literally gave me instructions on what was to happen if she died before the fetus was carried to term. In any case, it turns out that doctors are not God. God had a different plan. This lady is alive till today, 15 years later, more than 15 years later. You know, we made plans for her passing away. We never made plans for her husband passing away. He died in a car accident a few years later. He died without a will. We had a will for her, not for him. So I got involved in that family and their taking care of the kids in a whole bunch of matters. The stories of pain and suffering you are hearing are real. Death is not comfortable. Death is not good for anybody. This is not, there is no way of saying, of making this less of a catastrophe. I do urge representatives here to think carefully of a couple of institutional safeguards we as a broader society have placed. And one institutional safeguard we have placed as a society across religions, across cultural norms, across national origins, is to say every life is dignified, every life is important, every life needs to be defended. I am afraid, again, I'm not neither a legal expert nor a medical expert. I've never claimed to be either of the two. But I am very worried as a faith practitioner as to what happens in a society when that door gets opened. And I'm worried about a second door being opened, which is we want to interact with doctors on the basis of saving and preserving lives, not on the basis of hastening or enabling death. And opening that door also can have widespread societal consequences that I urge you to think about carefully before you were to approve any such bill. Thank you for your time.
Thank you for your testimony. Please introduce yourself for the record.
Yes, I'm Dr. Brian Collister. Thank you for having me, Madam Chairwoman and committee members. I'm a practicing physician in Northern Nevada. I'm a professor of medicine, although my views are my own. I'm also the sitting governor for Nevada for the American College of Physicians and was the chair for Nevada for the AMA's Organized Medical Staff Section. I've practiced medicine for 35 years, so why am I sitting in front of you? It's because of an experience I had. A couple of years ago, while teaching on the wards at our hospital in Reno, Nevada, I had two cases, happened about a month apart. Both of these patients needed a life-saving procedure. They weren't looking for palliative care or terminal or hospice care. They were looking for a curative procedure, and this was a standard procedure. It was not experimental. One of the patients was from Oregon. One of the patients was from California. I arranged a transfer, arranged the patient's acceptance at two different hospitals in those states, and then went on the phone with the insurance medical director in each case. They said, hey, Brian, we're not going to approve the transfer or the procedure. But by the way, have you talked to him about assisted suicide? I was stunned. I didn't know what to say, except, well, it's not legal here. And I said, well, it's legal here. And what really concerned me the most is when I went back to the doctor's lounge to vent on these situations, everybody, all my colleagues kind of had this resigned feeling about it. Not that they were for it, but they said, Brian, why are you surprised they offered it? It's legal in those states. And one of the criticisms that came across is, why didn't I turn these insurance companies in? Oh, this is terrible. Nothing they did was against the law. They denied one treatment. They approved another treatment. And I know in this proposed bill, there's language there that's supposed to protect from that. It says you can't coerce, an insurance company can't deny one treatment and accept another treatment. That looks great on paper, but I can tell you as a professor of medicine, how are you going to enforce that? How are you going to prove that? The insurance medical directors and the insurance companies say all the time, we approve this in this case and not in that case, and give real technical reasons why. What we're going to see is a movement towards the cheapest treatment, and I hesitate to use that term. And the cheapest treatment is to give you medication that will kill you. So let's not beat around the bush with this. This is really, to me, a scary thing, and this is what got me involved with this. I thought these are perverse and unintended negative consequences that people, I think, with all the right motivations, wanting to limit pain and suffering, I get it. But there are a lot of negative, perverse consequences that you don't realize. You hear that things are going swimmingly well in Oregon. I beg to differ. Somebody asked a question about the mental health referral. I do know the data. Less than 4% of patients in 20 years of Oregon data have been referred for a mental health evaluation. More importantly, how many have been denied the pills? for a mental health reason. That'd be a big fat zero. Zero. There is no required witness at the time the patient takes the pills. So once you get the prescription, which, by the way, having two doctors write it or agree with it, that's no safeguard. Don't we all know that physicians, we refer to like-minded physicians? And the terminal thing about 6 months or less, that's not a safeguard. I'll be the first to tell you as a full professor of internal medicine that our ability to tell you how long you have to live is sorely lacking. Our average error in most studies ranges from 50 to 70% off. The 6 months is the same thing you see with hospice. When I put somebody on hospice, which I do every week, love it. I put people on hospice, I have to certify they have 6 months or less to live. I put them on all the time. You know what? I take them off all the time when they've outlived their diagnosis. And I see them in the grocery store. I say, hey, doc, I'm still doing great. I say, good for you, and give them a hug. Nationally, 19% of hospice patients are taken off because they've outlived their diagnosis. In some states, that's a lot higher. In Mississippi, don't ask me why, it's greater than 40% of patients are taken off of hospice. So that's not a safeguard either. The other thing that you'll hear a little bit more about as it comes along is the reasons people choose to pursue physician-assisted suicide in Oregon. Pain and suffering doesn't make the top 5. The top reasons are loss of enjoyment in usual activities, burden to family, loss of autonomy. I agree, these are terrible social issues and they need to be dealt with. But last time I checked, the solution to the problem wasn't to offer you a terminal prescription. Throwing out the baby with the bathwater, I think, would be an understatement with that. And when you look at the reasoning behind this and the economics, compassion and choices, I see them all here, that morphed out of the old Hemlock Society, which was founded by Derek Humphrey decades ago. Derek Humphrey himself, in his book Freedom to Die, wrote, in the final analysis, economics, not the quest for broadened individual liberties or increased autonomy, will drive assisted suicide to the plateau of acceptable practice. Finally, the AMA CJA report, I don't think that description or interpretation you heard was really very accurate. The AMA Council on Ethics and Judicial Affairs voted to continue to adamantly oppose physician-assisted suicide, as has the American College of Physicians in their white paper. So when you think about the bottom line here, let's not take something where our goal, I think, is laudable to reduce pain and suffering and turn it into something where other people are denied care and other people actually suffer because of the legislation. Thank you.
Thank you so much. Can we have Stephanie Packer and Anne Marie Hansen?
Would you like my seat?
Thank you. All right, welcome to the Health and Human Service Policy Committee. Can you please introduce yourself for the record?
My name's Stephanie Packer, and I live in Southern California. First, thank you for being here and for listening to all of this. My biggest concern always at the foundation of it is educating and seeing all sides of these things and really taking a very close look at it, because there's nothing like it. This is life and death and heart, and it goes right to, the center of our being and how we respond to ourselves and the world around us. In 2010, I got really sick. I had already been diagnosed by then with the autoimmune illness, lupus, and it was not great, but roller coaster, which is standard for autoimmune illnesses. But in 2012, I ended up in the hospital, and the doctors were preparing my family to lose me. I was very lucky that there happened to be a physician in the hospital that day who saw some of my films and knew what was going on and had realized very quickly that I wasn't being treated for the worst parts of my disease. So there he diagnosed me with diffuse scleroderma, and with that, it caused pulmonary fibrosis. My form of the disease is, it's not always terminal, but I have the kind that it attacks my internal organs fairly quickly, and it's non-reversible. The terminal aspect of mine is the pulmonary fibrosis, where my lungs have developed scar tissue around them, and they continue to do that, so it makes it harder for my lungs to expand and contract. I have 4 kids, and right away we were very honest, letting them know what's going on and try to really give them all the information about my disease. And I then heard about physician-assisted suicide in California, and they were already well into it, and I had no idea what was going on. I immediately dove in and asked to, help anybody, because I wanted to stand against it for so many different reasons. And I get a lot of pushback from proponents of these. I understand what they're saying, and I get accused all the time of taking away someone else's voice, or to, that I'm pushing for pain and suffering because it's of something that I don't like. And it's really not that at all. In California, when they enacted this law, when it came to start utilizing it, I was informed from my insurance company that they were no longer going to be covering several of my medications. And when I called to find out what was going on and why it wasn't covered anymore where it previously was, they couldn't give me a lot of answers. And I told them, this was my last option. What am I supposed to do now? And the lady just said, I can't tell you options. I'm not a doctor. I can just tell you what we cover. And I asked about the assisted suicide drugs. And she put me on hold and came back and told me that those would be made available to me if I paid a copay of $1.20. I can't even begin to tell you what that is and what it feels like. And, we had been accused over and over of standing against this and putting out all these fears just to get what we wanted. And I was sitting here, and it wasn't a fear anymore that I was having. It was my new life and my new choice. I am nowhere near able of paying for medications outside. I mean, one of my medications alone is $8,000 a month. End-of-life care is the most expensive health care available. And insurance companies aren't in the business of healing, and they don't pretend to be. They are a business. And so if there's other options out there to save them money, they are good business people, and they're going to do that. So when I have tens of thousands of dollars a month to keep me going, they're never going to want that over the $300 they'd spend to give me this medication for me just to make everything stop. And I, along with so many around the world, I am determined to spend as much time with my children and my family as possible. Every single moment, every conversation, little things are there. And, when I see one of my kids playing and they fall and get hurt, they come and sit and, we snuggle. I can't fix it, but we can snuggle. And, sitting there and thinking about it and trying to figure out when I'm gone, because I didn't have enough money to cover it, who's gonna snuggle? Who's going to argue with them about everything? I've got some teenagers now. And I feel so lucky now to argue with my teenagers because none of us are guaranteed tomorrow, but with a terminal prognosis, it's a realization that is terrifying and beautiful all at the same time. We appreciate more and try to do more, and that's great. But our value is a lot higher than what we're showing patients. I'm not asking for people to stop believing what they believe. I'm certainly not advocating suffering. I'm advocating us to take care of each other. When someone's suicidal, we don't hand them a gun. We give them help and show them where support is and how to get through it. That's at our very core. When my kids first heard about it, my daughter just was ready to jump out of her skin. But they're not jaded with politics and these things. It's natural. Why would you want to do that? And why take that life? That's not what we do. It's not who we are. And we.
I need you to.
I'm sorry. So, there does need change. We need change, and we have to fix things. But assisted suicide is the wrong answer. It's the wrong answer for your state here. And it's missing the mark. And so for the government, for anybody there that's charged with representing other people, terminal patients deserve better.
Okay, thank you. Thank you.
Thank you.
Thank you. Can you please introduce yourself for the record?
Sorry.
My name is Anne Marie Hansen. I'm the founder and president of Gianna Homes, which are care homes for people with memory loss from early onset through hospice care. And this week we're celebrating 20 years of providing that kind of care in our community. Dr. Callister and others have given more of that professional concern that we have around putting this bill forward and improving it, assisted suicide. As we know, the most vulnerable are often those who have a diagnosis of memory loss. And we also, I can empathize, 20 years it's been my career of caring for people with this disease. It isn't easy. It is hard. It's hard on the caregivers. It's hard. It's not easy work, but I have to say my life has been given purpose to make a difference, to provide a home and an environment with the skilled care and services and programming and supports systems in place to help them thrive and live as fully as they can with this disease. So I want to be a voice for those of my patients and residents who can't be, and you come visit us, I'll show you the wonderful lives you can still live with this disease. It happens. I've done it a long time, cared for a lot of people, and I want to be part of a Minnesota that 1997 and 1998, we were trying to find new models of care for people with dementia, weren't we? And at that time, we only knew it was Alzheimer's. And I was part of that initiative in this state. We wanted to get away from the old nursing home model, and we wanted to find something new and creative to really meet the needs of those seniors who had different diagnoses and different needs of the generations before them. I hope as a state, we can really pause and think of that. This isn't a solution. This harms the relationship between a provider and a fragile individual with a terminal diagnosis. And it just really erodes at that sacred trust that has been placed in us. So I want to challenge us to kind of probably look for something different and be creative. I can also speak from the perspective of somebody with chronic illness. In January of 2005, I was diagnosed with a glioblastoma brain tumor. I shouldn't be here. According to statistics, research, and science, there is really, I'm an anomaly. I deal every day with seizures. I laugh with my staff. I have a Swiss cheese brain, and I'm not quite sure what I'm going to remember or not remember. But, you know, I still get to live life. My life has purpose. It has meaning. It looks different. But being ill and I have autoimmune diseases, and I deal with chronic pain every single day. Sitting here right now, I'm in an incredible amount of pain. And, you know, it's hard, and I get it. I empathize. But I hope we as a state, as neighbors, and as politicians pause and say, how can we step up and love each other and be present to them? And I want to share, when I was diagnosed with the brain tumor, and in those days, I was given 6 months to live. They really didn't have a lot of technology or science. Now we're seeing a little longer life expectancy. But I remember my neurologist saying to me, Anne Marie, I'm going to hold health for you. I'm going to hold that someday you can be better. And you know that I really clung to that because he was my ally, he was my friend. I knew he was going to do research, he was going to be with me in this journey. And I hope that my relationship with my physician doesn't get changed because of this bill. I want to know that I go to my physician to help me find cures for surgeries, or whatever it might be. Or also it may be, you know what, I can't have another brain surgery. But we'll talk about that together, and we'll work through it together. And it shouldn't be the place of politicians or others to make those decisions on my behalf.
Thank you. Thank you so much. Thank you both. So we have 20 minutes left to testify. Can I have Kathy Ware and Kylan Ware? Kathy and Kylan? They're coming? Okay, thank you.
I tell you what. Okay, he's gonna like that microphone, so we'll just go right here. How's that?
I'm sorry. Welcome to the Health and Human Service Committee. Could you please introduce yourself for the record?
Yes. So my name is Kathy Ware, and this is my son, Kylan Ware. Thank you. So I'm a registered nurse, have been for 20 years, and I'm a lifetime resident of the state of Minnesota, as is my son. Kylan has quadriplegic cerebral palsy. He has mental retardation, and he has intractable epilepsy. He also deals with chronic pain himself in his knees and in his back. I opposed this bill for doctor and nurse prescribed suicide because it devalues the life of people with disabilities. So I'm here as a disability rights advocate, and I have been a disability rights advocate for 25 years. This bill makes a public statement by law that death is better than living with disabilities like Kylan. So I'm glad we're talking a lot about Oregon here, because I'd also like to talk about Oregon here. Oregon has the death with dignity, right? Death with dignity. So for 22 years, Oregon Public Health has kept track of the rationale for why people choose to kill themselves and have a doctor help them. And here's what I want you to listen to in this. I want you to hear terminal illness and terminally disabled, because my son is terminally disabled, is he not? He's going to have these disabilities until the day he leaves the planet. So terminally ill or terminally disabled, or are we describing both here? Okay? Loss of dignity, loss of control over bodily functions, loss of autonomy, being a burden to family and to friends. Do you know pain is not even in the top 5 reasons over 22 years that residents of Oregon seek a doctor to help kill themselves? Not the top 5, okay? Let's just be clear about that. So let's review quickly. Death is preferable over losing one's autonomy. Suicide is preferable over losing your dignity. Suicide is preferable over feeling like a burden to others. And death by suicide is preferable over being incontinent or needing help in the bathroom, which I apologize, which is what we had to go take care of during committee. So again, terminally ill, terminally disabled. What do you think those define there? I know what they define. I know how the medical profession views my son and how people in general view my son. The definition of dignity is having value or worth, okay? My son is not undignified because I have to help him use the bathroom. Doesn't mean he's undignified, okay? My son is not undignified because I need to wipe a little drool off of his cheek or wipe his little nose when it runs. That doesn't mean he's undignified. My son is not undignified because some medical professions or other people would consider him a burden to society. I'm sorry. My son does not suffer from his disabilities. What he suffers from is prejudice and fear and the bias of people around him who do not assign his value as a man with disabilities as having value or being dignified. This bill bolsters bigotry in the medical profession, including my profession, which I've been a member of for 20 years, and I've been an MMA member for 20 years. The bill perpetuates the bias and the prejudice that it's better to be dead than disabled. I am asking you to stop this bill from moving forward and protect my son and peers like him in my state. There is no safeguard against bigotry. Thank you.
Thank you so much. Can we have Dr. Neil Wooden and John Bundrick? All right, welcome to the Health and Human Service Policy Committee. Can you please introduce yourself for the record and begin your testimony?
Hi, good afternoon. I'm Dr. Neil Budenseek. Madam Chair, I have written testimony for this. Good afternoon, everybody. It was a delight to hear that Bobby Joe Jacobson is from Richfield, where I grew up. I am a Minnesotan through and through. I am grateful for everybody here today, whether they're opposed to this bill or in support of it. My life's journey as a physician has been to work as hard as I can, hard as I know how to, and encourage others through great teamwork and collaborative care to provide the best comfort and support through excellent supportive and palliative care and hospice care. I've been an internal medicine physician for 16 years in Minnesota. I began my internal medicine career at Abbott Northwestern Hospital, just like Dr. Plimpton. I know Dr. Plimpton. And after 6 years, I transitioned to community-based care, leading the Alina Health Senior Health Geriatric Service in the area of rehabilitation and skilled nursing facilities. I oversaw 20-plus doctors and 30-plus advanced practice nurses, otherwise known as nurse practitioners. And now I serve as Chief Medical Officer of Benedictine Health System, one of the largest senior care Catholic organizations in the United States. In my spare time, I medical direct at 2 nursing homes in southern Minnesota and am hospice medical director for 2 Minnesota hospices. Actually, this afternoon, I was actively helping one of our blessed patients pass away in peace and comfort in one of our nursing homes. During this time, and I asked our hospice nurse, was she comfortable? Texting. And what I'm telling you is this day and age, the physical discomfort can be palliated successfully. The different domains of pain, which we really haven't heard about today, include not only physical, but psychological, emotional, spiritual, social, and financial. These are the 5 domains of pain. And as a physician, my job, whether it be as a palliative care champion and or a hospice medical director, or the Chief Medical Officer of Benedictine Health System, trying to understand better ways to innovate and have highly reliable systems and processes to drive excellence in supportive and palliative care. So none of our residents, including those that care and support them, our care partners, otherwise known as caregivers, can have a truly amazing experience working with those that they've been honored and called to serve, and to provide that comfort through the end of life and to the life beyond. Over the last 3 years at Benedictine Health System, our North Star has been to provide that excellent supportive and palliative care. And the only way we can do this is not by just talking about it, but implementing systems and processes that create highly reliable systems. Doing ordinary things extraordinarily well. This isn't rocket science. You can hardwire and create highly reliable systems and processes to drive comfort and support through the end of life in all of the domains of pain. And we're weaving these excellent systems and processes into every day, every care, every moment. We have palliative care moments in our communities. And we have over 30 communities in 5 states in the Midwest, assisted living, skilled nursing facilities, long-term care, short-term care, memory care. As a physician who is passionate about providing that excellence and supportive and palliative care to those who are desperate in need of comfort, especially when facing that advancing and terminal illness, I want to share a couple healthcare insights that I've gained in 16 years. First, it absolutely takes no great skill and very little effort to write the lethal prescription, but it takes consummate clinical and diagnostic skill, as well as a lot of time, effort to listen, empathize, collaborate with colleagues, scientifically and artfully prescribe medications, frequently follow up with the patient, and that cycle happens over and over and over until we together share that decision about how we're going to get you comfortable. A healthcare provider needs to devote the time and effort to intently study how that patient's symptom management is coming along. And achieving a good death, no doubt, is hard work. But it's valiant work, it's honorable work, it's blessed work, it's something beyond the work for both the patient, the care partner, the physician, the nurse practitioner, the hospice nurse, the skilled nursing facility nurse, the assisted living nurse.
Thank you. We're going to need you to wrap it up.
Thank you. The last thing I'd like to share is that I do strongly feel that my rights to practice medicine without being coerced into discussion of medical aid in dying as a normative medical treatment violates my First Amendment rights under the U.S. Constitution to freely practice my religion. I believe human life is sacred and that I must not do anything intentional to hasten death and kill. I also sincerely and humbly believe that I'm obligated for my religious convictions to not assist in writing a prescription for 10 or 15 grams of morphine or 100 capsules of pentobarbital. I am assisting. And that assistant includes referring to another colleague when I darn well know what I'm referring them for is to get the lethal prescription. This is a cooperative act. So with that, I adamantly believe every Minnesotan can experience the potential of palliative care in the years to come. If we say an emphatic no to medical aid in dying and an emphatic yes to better palliative care supports and systems, we have to remember death comes to us all, and no one will ultimately be safer or more comforted in Minnesota from House Bill 2152. Thank you.
Thank you so much. We have about 5 minutes left. I'm sorry. So just try to get through what you need for us to hear as quick as possible.
Madam Chair.
Please introduce yourself for the record. Yes.
Yeah, Madam Chair.
All right.
I know that we're under a timeline, but out of respect for the people that have come here to give us our testimony, I hope that you will look beyond the 5-minute timeline and give each one of these the respect due them for the testimony that they're willing to offer. So I think the committee is here strongly urging to hear all of the testimony. I don't think that a timeline should be placed upon the remaining 3 people.
We're going to work really hard to.
And I will
have
too,
each
yeah.
Testify to
Okay.
share what they need to share. So please proceed.
Thank you, Madam Chair and members of the committee. I'm John Bundrick. I've been an internal medicine physician in Rochester for over 30 years, taking care of patients with serious illness, including many at the end of life and in hospice care. I'm speaking from that perspective today as an individual citizen and not representing the views of my employer or any other organization. The stories that we've heard today are deeply moving for me, just as they've been with many of my patients. And I've felt this even more acutely over the past year and a half as I've walked alongside my sister in her struggle with cancer until it took her life in late July. But it's hard for me to imagine forging ahead with legalization of this proposed solution when a large segment of the medical community continues to have serious concerns about it. Recently, the 2 largest groups of doctors in the nation, after extensive study and vigorous debate, and under intense pressure to change their position, decisively reaffirmed their opposition to physician-assisted suicide. It's a term they chose carefully and with sensitivity, as do I, and with some reluctance, honestly. But only for sake of clarity and without intent to stigmatize anyone. The American College of Physicians, representing internal medicine, did so in 2017, and the AMA, representing all specialties, just this June, by a vote of 392 to 162 in their House of Delegates. And since there was some disparity in the earlier remarks with respect to Dr. Plimpton, the statement that they were reaffirming in that vote was that PAS is fundamentally incompatible with the physician's role as healer, would be difficult or impossible to control, and would pose serious societal risk. They clearly felt that the harms outweighed the goods. They did make some allowance for individual conscience of physicians. But clearly, many of my colleagues have deep reservations about this practice. And they recognize that even apart from the core ethical concerns, there are major issues with implementation as well. And these have been mentioned earlier. We talked about estimates of life expectancy being inexact. Separately, what I've seen many times, patients and their families struggle with the tough and complex decisions that must be made in the face of serious illness. I experienced that firsthand with my sister. And understandably, they may change their minds over weeks, months, years. It can be a very fluid situation at times. The desire to die itself will often fluctuate, and it can be influenced heavily by coexistent depression, level of symptom control, and other factors. But once the lethal dose is ingested, all opportunities for what might have been are lost forever. This bill seems motivated by a genuine concern to alleviate suffering and provide greater autonomy for the relatively small number of patients who would choose this option. However, it could harm not only them, but many others. The problem is heartbreaking and real, but this is not the solution. I urge you to oppose it.
Thank you so much for your testimony. Thank you both. Okay, now we have our last two testifiers. There's Reverend Jack Miller and Lynn Kempenmeyer. You really know, right? Welcome both to the Health and Human Service Policy Committee. Please introduce yourself for the record. Who are you with?
Madam Chairman, Chairwoman, members of the committee, I'm privileged to appear before you, and my name is Jack Miller. I'm a Lutheran pastor. I live in Millville, Minnesota. This bill, which has been eloquently discussed on both sides, and we've heard some deep and important positions taken. I will speak against this because this bill, to begin with, would legalize two actions that our civilization has long considered both a crime and a sin. The first is to legalize suicide. The second is to make it legal for a doctor to help the patient to do it. Both as a pastor and as an observer of our cultural reality, I understand why such a bill is before this body and why it has appeal in our present society. But I am persuaded, and I ask you to consider, that what this bill seeks to achieve is, first of all, unnecessary, and secondly, gravely destructive of our personal and societal understanding of the meaning of life. Such a bill as this is before you mainly because many people fear that, and we've heard this again and again today, a fear that at the end of their lives they will lose control of their situation. They want to be able to die on their own terms, and in particular, they want to avoid whatever suffering may be involved in the last stages before death. But this is unnecessary. And the doctors and others who have spoken here before me have eloquently described how this is unnecessary because of the advances in palliative care and the great advances that have been made in controlling pain and making dying patients comfortable, hospice care in particular. Yet an underlying fear of many people is that they will be alone. They will be isolated in a lot of medical apparatus. The response to this is not to artificially end the person's life, but to encourage families, friends, religious communities, and others to deepen their relationship with the dying person. The authors of an editorial in the Journal of Oncology Practice point out that, quote, the distress of those with terminal illness seeking peace of mind is understandable, but the remedy is education, support, engagement with the patient, rather than physician-assisted suicide. The former is care for the living patient. The latter removes the patient from the world of the living. A second reason for the demand for physician-assisted suicide is the idea of personal autonomy. which has become very popular. It's expressed succinctly by Frank Sinatra's famous song, "I Did It My Way." The reality is that we cannot be fully autonomous. Life and death exist beyond the possibility of our full control, and seeking ultimate control becomes destructive of our real relationship with our lives, which is to say, with our God. That relationship begins and continues to the end of our lives and beyond, with the fact that we have been created by God and that we are icons of God, because as we read in the first book of the Bible, so God created man in his own image, in the image of God. He created him, male and female, he created them. Or as the Apostle Paul puts it, you are not your own. You were bought with a price, so glorify God in your body. To destroy what God has created, ourselves, is to commit the most serious disrespect of our Creator and ourselves. In the words of the Catholic Catechism, it likewise offends the love of neighbor because it unjustly breaks the ties of solidarity with family, the nation, and other human societies to which we continue to have obligations. Suicide is contrary to the love for the living God, unquote.
Thank you.
These reasons that physician-assisted suicide is unnecessary and that it would be gravely destructive of our relationship with God and with one another, I strongly urge the committee not to approve this proposed legislation. Thank you.
All right,
I
thank
leave
you.
a copy of my remarks.
Thank you. Please, to testify, introduce yourself and who you are.
My name is Lynn
Can
Kemet
you
Mueller.
pronounce your last name?
Kemet Mueller.
Okay, thank you.
I am a hospice and home care nurse in Minnesota here. And I don't have statistics to give you, but honestly, I don't trust statistics anyway after I took 101 in statistics. And could you please pass those out? Thank you. So my faith informs my reason. So I want to just reiterate what everyone else has said in this whole room about life and suffering. Someone else said death is a consequence, and it's a consequence of sin that we are all going to suffer. And in fact, we are all dying right now. We just don't have that diagnosis, or maybe we don't know what we will die of. So with my faith informing my reason, I practice as a nurse, and my job is to help everyone else fulfill their job description that they get when the author of life places that breath into the soul into them at conception. So they're given a job description, and it's my job to provide the means for them to become who they can fully until their last natural breath, because there's a plan for every breath and heartbeat of every person in here, every person in the world. So it's my job as a nurse to try to implement and figure out, it's like a mystery. How can I help that person grow in whatever state they're in? So that's my love of nursing comes out that way. I mean, reflecting on just the day, I'm sorry, it is ironic that is 9/11 today, and we're meeting here to talk about suicide, and connected to that, the history of the suicides that took place on 9/11, which we all mourn. It's just a reminder that suicide is selfish, and it affects everyone. It's not a personal choice. It affects everyone. It will affect the families left behind. It will affect the physician that's involved. As a nurse, I'm already affected by the pressures of conforming to the culture of death. As a hospice worker, when I bring up ethical concerns, I'm silenced, I'm fired. I'm already tasting that. There are consequences of sticking up for your faith. And if you study the history of the states that have already made this mistake, it's pretty clear we don't want to go there. So someone sent me a an email about the Colorado man. Look it up if you can. He found out he had a diagnosis that was terminal, and it clouded his thinking. He wanted to end his life right away. It's kind of expected. You don't think clearly when you're grieving or hear news like that. So he sought the means to end his life, and without telling the priest, asked for a blessing because he was dying. Well, media warped it all to say, look, the Catholic Church is blessing this now. It's just like, whoa, that's not really what was happening. So I'm just saying, once the door is open, we've already heard it's the intention to push it farther, to expand it, they said. We want to expand it for maybe those that can't self-administer after they lose their ability. So that's a danger. So that slippery slope is real and maybe not as severe as mentioned, but it's real. And just specifics about the bill. I read through the fine details, and I thank you for bringing up about the death certificate, because it is falsifying information, saying that if someone has a terminal diagnosis and they commit suicide, that suicide won't be listed on there. It's very deceptive. So also, it hit me really hard when I was praying.
You
that,
have like 1 minute.
Okay, the word medicine, medical medicine, is used several times. And I looked at medicine, and it has to do with health. And I looked at poison, and it has to do with death. So the word poison really should be put in this bill instead of medicine, because that's the real effect of that lethal dose is termination of your life. That's suicide. So whether or not the person takes the pills that are at the bedside, how is it regulated that someone else could maybe come in because they know the intentions of the person, but they can't do it themselves, so I'll help them. That's not regulated. There's no witness, and that's not compassion. Compassion is suffer with. I will be with you when you're suffering. I will help care for you. I will be your hands when you can't move.
Thank you.
And just a reminder of our job description that we all get at conception until natural death. Today at Mass, the readings were Colossians 3:1 through 11, so look it up. It says, put to death, therefore, what is earthly in you, immorality, impurity, passion, evil desire, and covetousness, which is idolatry. On account of these, the wrath of God is coming. In these you once walked when you lived in them, but now put away all anger, wrath, malice, slander, foul talk from your mouth. Do not lie to one another, seeing that you have put off the old nature, which is with its practices, and put on the new nature, which is being renewed in knowledge after the image of the Creator. Amen.
Thank you so much. So that is our last testifier. And so before we move on, I would like to open up for any questions from committee members. Okay, Representative Morrison.
Thank you, Madam Chair. I wanted to point one thing out first. There's no requirement in the bill, to my knowledge, as I think Dr. Bundrick referenced, about requiring physicians to talk about this. So there's no requirement to do that. I did want to just point out that I think we may have different ideas about what happens after we die, but I think we all agree that our life here is finite. Death is a part of life. And I'd be curious, actually, to hear what Ms. Combs-Lee has to add about the experience in Oregon in terms of deepening relationships. I loved that Reverend Miller referenced the deepening of relationships around the time of death and around the time of dying. I think that is beautiful, and we should all strive for that. And I'm curious, Ms. Combs-Lee, if you have any comment or experience about what happens between the doctor-patient relationship in Oregon and how this bill may inform that.
Mrs. Lee, please introduce yourself for the record.
Barbara Coombs-Lee, President of Compassionate Choices. The Oregon experience has been exhaustively researched, and the data set is comprehensive and vast. If we were to stack up all the peer-reviewed journal articles about the Oregon experience, it would be a large stack indeed. One of the early studies was done by a psychiatrist at Oregon Health and Science University and the Veterans Administration Hospital. And she was interested in what are the characteristics of physicians who receive requests. Because in the first 21 months of implementation, something like 19% of physicians had some affiliation, some contact with it in their practice. But it was fascinating to me that, first of all, what you would expect, physicians who deal with dying patients, oncologists, palliative care physicians, they were more likely to receive a request. But one of the markers of a physician who is likely to receive a request was a physician who found fulfillment in the treatment of dying patients. Patients are very sensitive. They don't tend to approach their physicians with a request that is likely to offend the physician or be denied. I think sometimes we underestimate the sensitivity of our patients. So first of all, if a physician receives a request, they are generally more likely to be the kind of person who doesn't deny or shun or, like as we heard, not even tell their terminally patients that they're terminally ill because they don't want to deal with it. They're physicians who find satisfaction in the treatment of terminal illness. My own experience, the experience I think of most people in Oregon, is that a physician who receives a request and is willing to participate in the law finds enormous deepening of their relationship, not only with the patient, but with the family, with clergy, with whoever is brought into the circle of support. And these are some of the most meaningful experiences in these physicians' lives. Physicians often say, this has changed how I will treat my terminally ill patients. In fact, the respect, the integrity, the candor I'm likely to have with every patient. It's profoundly authentic.
All right, thank you.
Thank you.
Okay, Representative Albright.
Thank you, Madam Chair. I'd like to just follow up on that by asking a question of Dr. Collister. And while he's getting settled, Representative Morrison, if you want to take a look on page 3, lines 20 through 25, I think you'll find it fairly articulates that a healthcare provider must provide sufficient information to terminally ill adults regarding all available treatment options. So to your point, not seeing it in the bill, I just directed you to that point. Dr. Collister, to the point that was just identified in terms of the doctor-patient relationship, what have you found to be the change in that relationship when an insurance company delves into what is most appropriate or accessible to the patient when you're considering palliative alternatives?
From my experience, cost, whether it's explicitly talked about or negotiated, cost is always on the forefront of their minds, and that's how they approach any relationship. So anytime you create a situation where you have a financial incentive to limit cost, I think you're going to get into ethical problems. And in fact, I teach my residents every day, be very wary when an insurance medical director says something like, well, I don't think that patient's a candidate for that treatment or that procedure. It gets very nebulous like that. Of course, the begging question is, why wouldn't they be a candidate? And to segue off of that, one of the things that's happening in Oregon, pertinent to the last question, is it's really found itself since this law was passed in a general suicide crisis. Oregon's general suicide rate since this law was passed, and remember, they're not counting the suicides with physician-assisted suicide because it doesn't get put on the death certificate. So these are suicides other than physician-assisted suicide, have risen dramatically. From 1996 to 2010, in the first 15 years after this law was passed, Oregon's suicide rate shot up 48%. It's one of the highest in the nation. To make it really frightening is the suicide rate for veterans in Oregon has climbed as well, up 31% since this law was passed. Again, one of the highest suicide rates in the land. So this is not a simple little thing that just takes off and stays quietly in the corner. In 2017, 1997, 17 people took the prescription and died. Last year, that number was 143. And you hear, oh, it's a small number. It's almost tenfold the number that it was when this law was first passed.
Madam Chair.
Representative Albright.
Thank you, Madam Chair. Dr. Collister, we often talk in this committee about the patient-provider relationship. Maybe a little bit of an op-ed, but it certainly seems in past years like the insurance companies and the structure of our healthcare system has intruded mightily on that patient-provider. How would physician-assisted suicide and the costs associated, we heard from one of the testifiers that to realize the prescription for the assisted suicide prescription, it's $1.20 in the copay. Can you speak to just that?
Dr. Callister?
Yes, ma'am. Madam Chair.
Yeah, you just need to go through me. That's why I just.
Oh, no, I was just listening to the question. Absolutely. Sorry, Madam Chairwoman. I need to say, first of all, physician-assisted suicide is not yet legal in my state. But my familiarity comes not just from the 2 cases I have, but the bordering states. It's legal in Oregon and California. So, and I work 10 miles from the California border, so I have a lot of California patients. That being said, I've found the big change in the relationship is patients feeling guilty for being alive. That's the big change. So grandma has a chronic disease, she's winding down, she's starting to fail. And that's a time of life, in my experience, that's a great time for healing. It's the time where I believe you see the most love within a family coming together to take care of their loved one. And I'll have patients tell me, I don't want my family to spend all our hard-earned savings on my treatments. I want to leave them a little something when I go. I don't want to be a burden. And so that concept of not being a social burden, financial burden, or even just not feeling like they're not stoic enough for the family plays in. And I see physicians struggling with that quite a bit. And sometimes, unfortunately, I see physicians, in my opinion, becoming a little bit cynical. Like, if this is the way it's going to be, then, I'm not going to offer other things. They don't want it anyway. And then you have to wonder, back to these laws having no witnesses required once they get the prescription, what type of potential coercion goes on? It says 2 witnesses to get the prescription. One could be a family member, one may be the girlfriend of a family member or the boyfriend. And once they go home, there's no oversight. Nobody has to be there. In 90% of cases, no physician was there at all when the pills were taken. That's over 20 years of data.
So Representative
I
Albright?
just have one follow-up, a quick
Okay,
one.
because we have 4 other.
Thank you.
Members who like to. ask
Madam
questions.
Chair and Dr. Collister, I'm familiar with Dr. Gawande and his book Being Mortal.
Yes, I am.
You mentioned about the cynicism that has kind of creeped into the physician. I'm wondering, based upon the work that Dr. Gawande did in his book about making every day your best day, how this interferes with his thesis in that book.
Well, I can't speak specifically to what he intended, just, my interpretation. I say often to not only my patients, but my family, tomorrow's never promised. You can't relive the past 30 seconds. The song of life is here and now. We never know what's going to happen. We don't know what the future holds. And I think that plays into the length of time when someone's given a terminal diagnosis, that not knowing. If you get up and your feet are down and you're vertical, in my opinion, it's a good day. And you should make the most of that day. You heard from a testifier a few moments ago, Anne Marie, about her brain tumor, the glioblastoma. That's the same tumor Brittany Maynard had, the famous one who was on People magazine and went to Oregon. It makes me sad that we don't know how long she could have gone. With the radiation to the head, some people go a while. We know glios, in answer to your question, are terrible. What's the statistic? 70% are dead in a year. But I think he would flip that and say, that tells me 30% are not dead in a year, and 10% go over 5 years with a good quality of life. What's that to say? Are we going to create a culture where you're not only expected, but it becomes an absolute duty to die? When does the right to die become a duty to die? I'm frightened about that.
Okay.
Thank you, Madam Chair.
Representative Edison.
Thank you. I'll make it quick, Madam Chair. I just want to clarify, Dr. Callister, you had said that just in Oregon, you had talked about the suicide rates increasing between 1999 and I can't remember the end date.
Well, actually, they're continuing to increase.
Well, nationwide they are, Doctor, and I just wanted to make sure that we know that we're
This
being
is-
very clear about this 24%.
Edison.
Sorry.
I need.
I'm sorry. I get excited.
So let's Representative Edison finish her question, and then you need to go to
Yes.
me to respond. All
Yes,
right.
ma'am.
Thank you.
24%, the number went up in the U.S. Thank you, Madam Chair. And then just if you could just answer this question for me. When people die, when they say they jump from a burning building, in your opinion, is that suicide? The building is burning. Because that happens every day in America.
So to answer your first question, I had 23%, and that's from the CDC. So the national suicide rate increased by 23%. During the same time period, the Oregon suicide rate increased by 48%, more than double the rate of increase of the United States increase as a whole, doubled it. In answer to jumping from a burning building, I don't know that I can even offer an opinion on that, because so many things like that, whether it's to try to save yourself suffering, or if you really were despondent and jumping off the Golden Gate Bridge instead of a building, who knows what you're thinking at that 1 second. So many suicides are impulsive. There was an elegant study done of survivors of jumping off the Golden Gate Bridge, and it was very interesting. Not many people survived that jump, but of the few that did, the overwhelming majority said they regretted doing it on the way down, even before they hit the water, and they chose to jump. Back to your question specifically on the burning building, I wonder where impulsivity plays in right along those lines to this law. I'm a stoic, grumpy old guy, and I just got a terminal diagnosis, and I'm grieving for myself, and I've got 6 months or less to live according to my doctor, and I'm going to go get that doggone prescription, and on a dark and stormy night, it's in my nightstand, I just might take it. And you can't take that back. You can't take that back. I worked for a long time with a patient and friend who had a glioblastoma, and he told me that if the pills were available on a dark and stormy night in month 5, month 6, he would have taken them. And he went 4 good years and had 2 children during his 4 good years before he finally got sick enough and passed. So we have to be careful that we don't limit the possibilities because of our fear and our impulsivity, and create, again, perverse incentives that we can't walk away from.
Representative Edison.
Thank you, Madam Chair. I think it's also important to not to villainize people that are making.
Oh, no, not
I
at
mean,
all.
the reality is I draw that comparison because it's very similar to probably somebody that feels like they have no other choice. And so, Doctor, I respect your opinion. I really respect all the opinions that are in opposition of the bill. I think it's really important that we hear from you. So thank you for being here.
Thank you very much, and
Representative.
really feel good about it.
Representative New. Move on.
Thank you, Madam Chair. Dr. Callister, I guess I would just ask, in looking through this, is there objective criteria for physicians to prescribe these medications to patients?
Dr. Callister.
Yes, Madam Chairwoman. I don't see that. I don't see it. 6 months or less to live, requests the medication, has 2 doctors say in your best medical judgment at 6 months or less, but it could be almost anything. I mean, in the Oregon data, very few, I'll grant you, very few cases are this way, but there are some over the 20 years that didn't have a terminal diagnosis listed. There was uncontrolled diabetes listed. There's respiratory insufficiency. Also keep in mind that the designation for terminal doesn't specify terminal with treatment, which means theoretically, and I don't know, I hope it's not happening practically, if you stopped taking your medication for an illness that would be terminal if you chose not to use your medication, you would technically fall under the auspices of the bill. So an insulin-dependent diabetic that said, I'm tired of it, I'm an impulsive 18-year-old kid, I'm going to stop taking my insulin, by these definitions, they'd qualify. Because a type 1 insulin-dependent diabetic would most certainly be gone within 6 months, in most people's opinions, if they stopped their insulin. So it's kind of difficult.
Representative New?
Thank you, Madam Chair. May I share a few comments?
Yes.
Thank you, Madam Chair. I appreciate the things that have been said, and from both sides. Clearly, end-of-life issues are the most difficult issues any of us will ever have to deal with, whether for ourselves or for our loved ones. And I bring up this question about ALS. I think it is significant, and I think it is significant to know when people are self-administering this mechanism of suicide, because people do lose that ability quickly to self-administer with ALS. My husband, 6 years ago, was diagnosed with ALS, and so I had lots of conversations about this. And what I find interesting, and a conversation that I remember very clearly, very early on, as we discussed the possibility of him being on a ventilator, is we asked the doctor, what did that mean? Does that mean he's going to be in a hospital for the remainder of his days? Is he bedridden? What does that mean? And certainly he gave us the information on that. And then he also told us that patients who chose to go on a ventilator self-reported a significant quality of life once they were placed on that ventilator. Caregivers reported decreased quality of life. How many people, in fear of being a burden on their families, make that decision to end their lives?
Yeah, Madam Chairwoman. Oh, did you finish?
Representative.
It's rhetorical. It's rhetorical.
It's a tough one.
It's a rhetorical question. The problem is there is no answer to that. But we do know it's happening. And it was a little concerning to me that this idea that physicians were the ones sort of checking these boxes on this survey, saying, what their patients had expressed as reasons for choosing suicide. It was a little disturbing to me that the testifier was a little dismissive of that. And I thought, this is the same physician who is determining that this person is of sound mind to commit suicide. And then we're saying that same physician is not qualified to say why?
So, Madam Chairwoman.
It's not a question, really. It's just a statement, and we're going to move on.
Okay.
It is just a statement. Listen, there are plenty of personal reasons, deeply held personal reasons, and I want to thank Ms. Ware for her remarks, because I certainly feel the same way. We hear a lot about death with dignity. I assure you that my husband died with dignity, that when he was paralyzed and could not even move his head from side to side on his own, we had to do that for him. I assure you, there was dignity in receiving the love and care that he received from his family. When my teenage boys had to help change his underclothes when there was an accident, I assure you there was dignity in love in those actions. The arguments for this have been framed in a way that, frankly, are really disturbing, when we look at the love and care that people should be receiving at the end of their life. The fact that we use those phrases and turn this on its head is really disturbing. So certainly there are personal feelings for all of us as to why we are for or against this, but I think there are some really critical questions that we all need to consider. honestly, I had this down as a theoretical item on my paper. Who benefits from this financially? Insurance companies. I was shocked that there was testimony saying of very specific examples where insurance companies have made decisions based on this option. What are the objective criteria? There is no objective criteria. We talked about ALS in 6 months. I was told that John could have had a hospice diagnosis immediately. They would provide that to him because of the care that he would have received with a hospice diagnosis. We could have had that anytime throughout that process. When I was in college, I worked in hospice. I can tell you about a number of patients I took care of who lived for years with their 6 months diagnosis of hospice. This is not some magic number. What happens when a patient has a primary care provider who has a personal philosophy that the cost of end-of-life care is too expensive and that this is a good, viable option for those patients? How are those patients influenced by those providers? I heard a number of times today the phrase that we are allowing people to own their own suffering. There are a lot of people in this world suffering. Frankly, it was offensive the way the slippery slope argument was talked about in comparison to eating potato chips. This is not the same thing. But at what point do we just allow people to own their own suffering? All of them. These are legitimate concerns. I hope that we will think long and hard before we move forward with this kind of legislation.
Thank you, Representative New. So we have four members on the list. But I want you guys to keep in mind, this is just an informational hearing. It's possible that, if we bring it back in 2020, you will have plenty of time to talk on this bill if a vote was going to be taken. So just keep that in mind. We have 3 other bills that would like to be heard this evening. And there's plenty of testifiers who have signed up for the other bills to be heard. So if it's not really necessary for you to make a comment, please just hold it to the bill if and when the bill is brought back the next time. Representative Keel.
Thank you, Madam Chair. Actually, Representative New covered everything I would have said, so thank you.
Thank you so much. Representative Robbins.
Thank you, Madam Chair. I'll be brief. I just had some practical questions when I was looking at the bill, and so Dr. Callister, you can ask, or
Sure.
Representative Freeberg, if you want to address it, whoever wants to address it. The first was, this question has come up several times about someone is given the 6-month diagnosis and maybe they take the prescription, but what if they actually indeed live longer? I had a dear friend pass of ALS who lived much longer than her original 6-month diagnosis when she got to the 6-month point. So if someone is given the 6-month diagnosis, they get the prescription, but then they're still doing relatively well after that 6 months.
Yep.
Does someone take the prescription back, or is it reevaluated? Like, what happens at that point?
Madam Chairwoman, sorry, I got the data on that right here.
One moment. One moment. I think I'm going to let Representative Fiber respond first, and then we can hear from Dr. Callister. Did you want to respond to that, Representative Fiber?
Yes, thank you, Madam Chair. Thank you, Representative Robbins. We heard data from Oregon that only about 1/3 of the people who are prescribed the medication actually end up using it. So, I trust doctors generally. I heard the doctor here saying misdiagnoses happen frequently. I guess I trust doctors a little more than that. I'm not a medical professional, but I feel like if they...
It's not what I said.
Could you please not interrupt, sir? Thank you. I feel like if they... sorry, I kind of lost my train of thought there. I do feel like if they come up with a diagnosis of 6 months or less to live, they're generally going to be accurate. They're medical professionals. I think going by commonly accepted practices of the medical profession is really the best we can expect of them. I imagine if people are still living after the 6-month diagnosis, that's a wonderful thing, and I imagine they would probably not take the medication. Not everybody does.
Okay, Dr. Callister?
Yeah.
Briefly.
Brief. Madam Chairwoman, it's not so much misdiagnoses as outliving the life expectancy that would be the median for the diagnosis you had. So the diagnosis is often correct. In 2017, there were 218 prescriptions written in Oregon and 143 deaths. Now, 40% of the people on average die in the year they receive the prescription. Up to 60% do not. In previous years, we have data for 16, 15, and 14. 19 patients in 2016 died with a prescription they received in previous years. 7 in 2015, 11 in 2014. So on average, it's about half the number of deaths as prescriptions written per year. And there is no paper trail on what happens to those prescriptions if they go unused.
So I'm gonna have to make an executive decision here, you guys. I really am. I'm gonna have to make an executive decision because this is on an informational hearing, and I know this is something that we have lots of passion. It's hypothetical. No one's here who a family member who's been impacted by someone losing their lives. So he's talking to someone who is speaking from a different dimension, and here's someone, I know Xerox is here, Representative Xerox is here. He has a firefighter he would like to testify who needs to leave and travel back home. And so I'm going to make an executive decision here. We have 3 other people on here who would like to speak, and I'm going to say we're going to pass. We're going to pass, you guys. It's only an informational hearing. We're not going to vote on this. It's not going anywhere. And if we bring it back, you will have more than enough time to debate and talk more about this bill.
Madam Chair.
Sorry, Representative Pearson, Loeffler, and Bonner. Those are the 3 that's on, you're on the list. We can exit the doctor from now until tomorrow, his type, and what?
Madam Chair.
Representative Pearson.
Thank you, Madam Chair, and I appreciate your executive decision, and I respect that. In the previous legislative cycle, I didn't find that to be true. I felt as the minority member that we were oftentimes limited on debate, and as I'm not going to make a big show of that today. I just want your commitment that we would have an unlimited debate schedule for this specific bill, should it come up in future sessions and you are the chair.
I just want to say, in my time as chair, last session, I think I was pretty open to allow a good debate on both sides. But I do promise that if this bill come back before this body for a vote, you will have unlimited debate and conversation about this bill. Okay? So thank you so much for coming to testify. Representative Freiberg, I don't know if we need a closing statement or not, but if
I can be very brief. I want to respect the time of everyone else, but there were a couple misstatements about the bill that I just want to clarify very quickly. First of all, I just want to draw members' attention to the provision on line 11.1 that says there is no duty to provide medical aid in dying, and it says that a healthcare provider may choose whether to provide medical aid in dying. So there's no requiring doctors to provide it. I'm generally not in the habit of defending what insurance companies do, but there was a fair amount of discussion about insurance companies. Generally speaking, I think the insurance companies would say that they may choose not to cover what they deem expensive or experimental. I don't know the specifics of the cases that were discussed, and I have made efforts to require insurance companies to provide additional services where they haven't. But some insurance companies do cover medical aid in dying, and there are some that don't. So I think that's important to mention. There on line 3.18, the definition of terminal illness means an incurable and irreversible illness. It has to be irreversible. So there isn't, in the doctor's judgment, if there's a possibility they can be treated, they're not going to be eligible because then it would not be irreversible. Finally, I want to speak just to the phrase death with dignity. That is not a phrase that I generally use in regards to this bill. That is the name of the law as it was passed in Oregon. It was passed by an initiative brought up by the voters, not by the legislative body. We don't have that process here. I agree with many of the people who spoke in the second half of the testimony. There's dignity in every life. And I thought Reverend Limpert spoke very eloquently about people may find dignity in the suffering that they're going through. People may find dignity in living out what they view as a natural death. And others may view this as having dignity. That's all equally true. This bill is the End of Life Options Act, which I think is a much more accurate title of the bill. At the end of the day, this is about the patient. This is about what patients are going through and the government not telling them what they have to do and how they should live the end of their lives. It's not about what we think as politicians. It's about the patients. So thank you, Madam Chair. I really appreciate the time.
Thank you. Thank you so much, Representative Freiberg.